So, I'm going to talk a little bit about the diseases MDA covers first. In other words, a spectrum, what we call the motor unit. I'm then going to talk a little bit about something that is a little bit difficult, but I'm going to try to make it easy for you. And that's some basic genetic concepts, because many of the exciting things that are going on.
You can click through right here.
Oh, good. That's fine.
This is working.
Yeah, that means I can't. Is the pointer working?
I'm not sure.
Is that the pointer? Don't look at it.
It was working before.
Okay, so pointer doesn't work. Let me. Oh, can you see that on the screen when I do that? No. Okay, so I'm going to talk a little bit about genetics, because understanding some of the really exciting things that are going on, and understanding that we're learning about neuromuscular disease gene by gene is really important, because when I get to what's new in neuromuscular disease, there's a treatment revolution going on, much of it in the genetic arena, although there's other things as well. And we're going to talk about some new trials that are coming that are really exciting, and everybody I know is interested in, and new treatments. There we are. So you heard that MDA covers 43 diseases, and there's actually many more. It depends, for instance, how you define something like limb-girdle dystrophy. Limb-girdle dystrophy was one disease in the past. We now know that there are more than 30 different genetic variants, 30 different genes, which are part of our DNA, and we'll talk about that in a moment, that can be damaged, resulting in disease, all of which is progressive weakness, previously called limb-girdle dystrophy. So is that one disease, or is that 30 diseases? So MDA actually covers many more than 43 diseases if you break it down genetically. Oh, is this so I can walk around? In case I want to dance around, you know?
And there's your laser pointer if you push the red button.
Oh, good.
Point
Thank
at the
you so
screen.
much. So, yeah, I may be able to, then I definitely have to walk around. Let's see. Yeah, I don't think the laser will get to, oh, yeah, maybe it will. Yeah, there are two screens, but, so, anyway.
Don't use the pointer here, that works.
Does that work a little better? Yeah, it depends on your angle is the problem.
Squeeze this one and this one.
Yeah, okay. So I may have to just walk a little bit. But, so MDA covers diseases, neuromuscular diseases, which are diseases of what we call the motor unit. The motor unit is the nerve cell, let's see if this works, as it comes out of the spinal cord. I can't even find it if I'm not taking someone's eye. There we go. As it comes out of the spinal cord and innervates muscle. So MDA covers diseases of that nerve, of the junction between nerve and muscle, and of the muscle. And some of the more common diseases are listed up there. So in terms of diseases that affect that motor nerve as it comes out of the spinal cord, we have things like Charcot-Marie-Tooth, we have spinal muscle atrophy, ALS and its relatives, and Friedreich's ataxia. In terms of neuromuscular junction, that's myasthenia, Eaton-Lambert, some congenital syndromes that are inherited that damage that motor neuromuscular junction. And then we have muscle diseases, specifically those diseases that affect the muscle, the inherited diseases, which at one point we all called them all muscle dystrophy, but now we have Duchenne and Becker's, we have myotonic dystrophy, we have the limb girdles, which I told you, 30 different diseases right there. FSH, oculopharyngeal, so there's a whole list. And then we have inflammatory myopathies and problems with metabolic myopathies, which are problems with the way your muscle makes energy. So there's a whole lot of disease to cover, and that's why I say this is a whirlwind tour, and I'm going to touch base on the most important ones. But to understand, and is this visible when I do that? No? Is that arrow visible, guys? No. Okay, so it's a little bit hard, but what you see here, we all have a bunch of genes. We call them chromosomes. Chromosomes are basically a string of pearls, each pearl being a gene. Each gene carries the information on how to build the house, brick by brick, each brick being a protein. And so we get half of our, and then we have 22 chromosomes, or 22 pairs. One of each pair comes from mom and one from dad. And then we have our X and Y chromosome, and I hope I'm pointing right because I'm really pretty blind. And those genes are carried in the brain of every cell, the nucleus. And in order to transmit the information to the cell machinery outside of the nucleus, you create what's called RNA, which is a single strand rather than a double strand. So here you can see there's a double strand of information. That information is a code, and the code contains basically 4 letters or 4 nucleotides. The DNA splits open and creates a single strand from a double strand. That single strand helps to create RNA, which becomes the message. And RNA is a single strand that carries the message out into the cell and starts up the protein machinery. And we're going to see how that works. You can see over here, because I can't see well enough. You can see over here the single strand of RNA informing the cell, telling them how to put those bricks together, how to put what we call amino acids together to create a protein. And then the protein goes and does its job. And, in the case of muscle, that's some of the things that go awry. And it's not quite that simple because that DNA forms, and I'm only showing you this because it becomes important later when we talk about some of the new therapies. Here's my DNA, and it's got a code. It splits open and allows the cell to create what's called pre-mRNA, but only some of the information is going to be used by the cell to make protein. Those are called exons. The rest is called introns because it doesn't get used to make protein. We call it internal information, but it creates some directions. That's those directions you always throw out and don't read when you put something together. Well, they tell the cell how to put these exons together, and then the exons go out into the what we call the cytoplasm, where the cell machinery is, and get made into protein. And so this is a little bit to give you an idea. Think of this as sentences. So we have a code, and every 3 letters, each one representing a nucleotide. Remember those building blocks, that alphabet represents a word. So if everything's working perfectly, you can see that first line, normal. That spells out DNA has all you can ask for. Those are like putting proteins together, or what we call amino acids. But if you might have one change in that top sequence that results in a change in a letter that's silent, meaning it doesn't make a difference. It still sounds like DNA has all you can ask for. But sometimes you have a change that just turns the whole sentence upside down. And that's DNA has all Lou can ask for. That's a missense. It's not giving you the same meaning that you should. And sometimes you put a change in that stops the sentence midway. That's called nonsense because only part of the protein would be made and it gets degraded. And then finally, you add something in there accidentally and you can get a whole shift. So DNA has, and then the rest of the sentence is total garbage. Okay, and so that's what happens. The protein that's made, if there's one of these frame shift mutations, is totally out. So that's a little bit of our genetic lesson today. And then, as I said before, you get one set of genes rather from mom and one from dad. So you can inherit these changes in different fashions. And some diseases, you need only one damaged gene to get the disease. And you're going to hear about this a little bit later from genetics. That's what we call autosomal dominant, meaning one bad gene and you're going to manifest that problem. Sometimes you need two bad genes. And that means mom might be a carrier and dad a carrier, and then you inherit both of the bad genes, and that's called a recessive problem. Sometimes it's carried on the X and Y chromosome. Remember I said you have 22 what we call autosomes, and then 2 sex chromosomes, an X and a Y. You always get an X from mom and a Y from dad. And XY makes you a boy, XX makes you a girl. So dads carry an X and a Y, and depending on which one they give the baby, it's going to be a boy or a girl. So some can be on the X chromosome, and they can be recessive because the Y chromosome doesn't have information to combat it. So you have a damaged X, but there's no information on the Y because it's a smaller chromosome and doesn't have as much. And then finally, there's a separate inheritance for diseases that affect the powerhouse of the cell called mitochondria. We'll talk a little bit about that later, but mitochondrial mitochondria have their own DNA, and that can drive disease as well as the DNA that's uniquely ours from dad and mom in the nucleus. And all your mitochondrial DNA comes from mom. So why did I give you all this? Because this is the age where genetic manipulations are making a difference. And when you read about these genetic manipulations, having a little bit of background information will help you understand. So, for instance, in CMT, we've generated a clinical trial now where we use a virus to deliver the gene for a neurotrophic factor called NT3, which will help to preserve the nerve cell. In ALS, we have 2 trials going on that block the production of abnormal DNA, because you can, and I'll talk a little bit about that, because you can live without the gene. They're called antisense strategies. In Duchenne, there's been a huge progress made with exon skipping. So, I showed you those missense and abnormal mutations. So as you're going along, if you come across a bad area of genome, can you skip over it and reestablish normal read? And I'll show you some examples of that. That's what we call exon skipping, and that's actually a therapeutic that's available now, and others are being tested for different areas of the Duchenne gene. There are ways to push reading through one of those stops. Instead of stopping, you can push across it and reestablish again reading frame. People are looking at that. Removing bad DNA to reestablish and non-essential DNA to reestablish. Removing the whole gene and putting in a new gene. We call that CRISPR. And you're sitting there going, oh my God, it's been done in mice now. That means it will transition to people. So understanding this genetic stuff becomes really important because this is an explosive age. Limb-girdle dystrophies, those 43 diseases, well, it becomes, or those more than 30 diseases, it becomes important to know which one you have, because now we're going to have gene replacement therapy. SMA, it's in the clinic now. Using a splice modulating oligo that re-establishes or helps to make a normal protein from a sort of gene we felt was useless. And again, I'm going to show you that. But this is real. This is not airy-fairy. This is not tomorrow or 10 years from now. This is now. This is the progress we're making now. And some of it is, a lot of it is thanks to MDA funding. Again, we are also learning how to deliver the whole Duchenne gene with a virus. We are replacing protein that's missing in Pompe's. Used to be a horrible disease. Kids died by 2 years of age. We can replace that. It's now in the infant newborn screening panel to look for that disease so we can treat it immediately. So these are all important. So let's start. We're going to talk now. I'm going to do my, ready, deep breath, whirlwind tour, okay? So I'm going to talk about a little bit about that lower motor neuron, the anterior horn cell, part of that motor unit. Remember, it's the anterior horn cell, the neuromuscular junction, the muscle. So we're going to go through some of the diseases. So Charcot-Marie tooth, we have 2 major types. And again, it's not only 2 diseases. each one, type 1 and type 2, has several different genetic variants. So when MDA says they cover 43 diseases, they're really, they're being modest because they're covering a lot more than 43 when you think of each genetic problem being a different disease. So type 1 means the insulation of the nerve is damaged. And again, I'm trying this, but my vision is so bad. So here's the nerve, and you have an insulation and you have a wire. Type 1 damages the insulation called myelin, and type 2 is when there's a problem with the wire. And type 1 is typically autosomal dominant, meaning one bad gene, you get the disease. And type 2 can be dominant or recessive, and there are several variants. And it causes progressive weakness and sensory loss, typically starts in the feet and then the hands. And as I said, there are more than 20 different possible genes now. That's 20 different diseases. How many are we up to now? 43 plus 30 plus 20? That's what MDA covers. And so then we have some of the new things that are going on. What? I got this.
It has to be in here for this to work.
For what?
Unplug that.
Yeah, go ahead. So there are a couple of trials going on. One is a combination drug. And so is this going to work now? No. They're trying to get the remote to work. This will probably persist through the day. I hope you didn't pay a lot for the AV here, Ed.
Use this one.
I'm teasing. Yeah, it has. Okay. Oh, and look at that. Okay. While playing, we changed the slide. So now I can see. So we have several different clinical trials. This is a combination of 3 agents, and this is in a phase 2 trial by Acceleron. And so, by the way, a phase 3 trial. By the way, you guys know how to look up clinical trials. MDA has a vehicle on, a link on their website to look up, or you can go to the nightmare that's called NIHclinicaltrials.gov. And, just put in enrolling trials so you don't see a million things. The problem is you'll get clinical studies as well as clinical trials when you do that. So this is a phase 3 study that looks at 2 different doses, and it's looking at the effect of disability in Charcot-Marie tooth. There's also ACE-083. This is a drug that's going to be injected right into the muscle. There's been some promising results in CMT, and it's also looking at some other diseases too they're using it in. We'll talk about that later. But it enhances muscle growth, so the muscles get bigger and presumably stronger. And that's the hope. And then here's that pesky genetic stuff. In addition, there's a trial ongoing using a virus, what we call viral vector, but it's a virus to deliver a factor called NT3, which is a sort of factor that nourishes nerves, a neurotrophic factor, deliver that to muscle in Charcot-Marie tooth. So some exciting trials going on. Oh, I have to use this one now. ALS, near and dear to my heart, obviously, as you heard. This is a disease that affects 2 sets of nerve cells, the upper motor neuron that brings messages down from the brain to the spinal cord, and the lower motor neuron that then causes damage to the muscle itself. So you have the messages just don't get down to muscle to move. And as a consequence, you get atrophy, which is thinning of muscle, weakness, and twitching, which is due to the damage to the lower motor neuron. And then you get a stiffness and increased reflexes due to damage of that upper motor neuron. And it can present with trouble speaking or swallowing, which we term bulbar difficulties, or with extremity weakness, and it is progressive. I'm not going into much more about ALS other than to say this. It has been a major explosion in terms of genes. You can see back in 1993, we had the first gene identified that about 10% of people with ALS have a familial variant. And the first gene associated with familial ALS was identified in 1993 called SOD1. And based on that model, based on that genetic abnormality, we developed a model to study disease. However, starting sort of in the early 2000s, we began to identify multiple other genes, and you can see the explosion most recently, and we are now up to 34 different genes that have been identified in familial cases of ALS. And in fact, and importantly to remember, in people who have no family history, there's also sometimes found to be genetic abnormalities that have been identified previously in the familial cases. And the one that I have in red, C9ORF72, is responsible for 40% of familial cases, most common, and up to 7 to 10% of cases in out of the blue where we have no family history. 7, and then 40% at 10% is 4. So basically what I'm telling you is that between 10 and 15% of all ALS is due to that genetic abnormality. And guess what? We have a clinical trial coming up where we block the abnormal part of that gene from producing an abnormal protein. So genetics is important. And if successful, that treatment will help us with 15% of ALS in a disease that is, as you know, uniformly progressive and difficult. There's a very few people who plateau, but there are some people. And this just shows you the other advantage of all this genetics. You see all the red words there. Those are all genes that have been identified as causal in ALS patients. And the point of this slide is only to see that these genes are important for cell mechanisms across the cell, from RNA, DNA to RNA to protein, packaging of proteins, shuffling of proteins up and down the nerve cell, where you see the motors and the enzymes dynactin, the cytoskeleton, which is a framework. That's like the framework of the house. Okay, you build the frame and then you put the shingles on, the framework of the house, and also to inflammation and reactivity. So we are learning motor neuron biology gene by gene, and each one of those processes then become a target not only for genetic manipulation, but for medications. And the same is true for all the diseases we're talking about, that as you identify the processes that when they go wrong can create disease, you can target those processes with treatment. So genetics isn't only about replacing genes, it's also about creating a notion for what the targets could be, what mechanisms and processes in each cell, muscle, nerve, we should target. And so this has created a whole pipeline for ALS. And so we have 3 drugs that have clearly been approved, and Radicava being the one from the last year, Radicava or Darivone. That works by free radical scavenging. We've had Rizol around for a long time. That's an anti-glutamate. So we're chipping away and slowing the disease down, and it's step by step. I don't have time to go into it, but for people in the audience, who do have motor neuron disease or ALS, this is a heterogeneous disease, and it's going to take personalized medicine and chipping away drug by drug, gene by gene. But you can see that we have a whole pipeline, and the bolded, some of those bolded drugs and interventions, those have been shown in early results to have positive effects. And in addition, in addition, I told you I was going to tell you about gene therapy in ALS, or a little bit. There are 2 known mutations that are responsible for more than 50% of hereditary ALS. And remember that C9 is responsible for at least 7% of sporadic ALS. So really we're talking about a total of 10 to 15% of all ALS. And what are we doing? We are creating a strategy where when DNA becomes RNA and single-stranded, we block it with what's called antisense. It binds to that RNA and keeps it from producing the bad protein. That is now in clinical trial for SOD1, and we're working on bringing it to the C9 patients. So this is not airy-fairy. And then what everybody wants to know is stem cells, right? Because stem cells everybody's excited about. And there's been two major stem cell trials, neural stem, where the stem cells were directly, can I do it? Where the stem cells were, can you hear me when I walk away? Where the stem cells were directly injected into the spinal cord, and that was found to be safe.
Actually, they cannot hear you over here.
Better when I stand here. See, I'm paying special attention to this side because I can reach it. But I'll try this side. There's been, see, there we go. So there's the neural stem where the cells were injected directly into the spinal cord, and that was found to be safe, and you can't judge efficacy. Remember, phase 3 trials, phase 1 and 2 are, do you kill anyone is phase 1. Phase 2 is what's the dose? Playing around, looking at adverse events, and figuring out how you should do the full trial. Phase 3 is when you're really looking at efficacy, just so everybody knows. And you really can't generalize from a phase 2 to a phase 3, but in any disease, what we want to do is get a signal that we're in the right direction, okay? So here you can see they inject directly into the spinal cord, and it was safe, and nobody really got hurt by the treatment. It has not moved further along yet. I think the company is trying to capitalize. The second, and all the hype, at least in ALS, is the brainstorm. It's phase 2 now and phase 3. This is where they take bone marrow, create stem cells from your own bone marrow, and inject it back either both in the muscle and through the spinal fluid. The earlier results are shown in those graphs, and in the first one, the blue is treated and the red is the placebo patient, and you can see, and it looks at the change in a functional score, and you can see that in the patients who were treated, there was a suggestion early on after the injection that they did better. And when you see that, I don't know if, let me see, it would work better with this. I wish this showed up, but does it show up? No. Whoa. You want to start from the beginning again? I'm sure you do. So you see this line. Prior to the injection, everybody got worse. After the injection, the treated, which was blue, got better. And then if you looked only at rapid progressors, it was even, who are people who changed more rapidly, that was even more, oh boy, more impressive. Yeah. So is that better? Can people hear me a little better if I do that? Okay, because, So, and then there's also another stem cell trial going on at Cedars-Sinai in which they're giving stem cells that actually carry a neurotrophic factor called GDNF, and that's ongoing. So stem cells, I spent a little more time because everybody's always interested what's going on in stem cells. Kennedy's disease is one of those X-linked diseases where there's a problem with the androgen receptor. It's mainly men, women are carriers, and it's slowly progressive. It starts with speech and swallowing. Men can get large breasts with it because it's an androgen insensitivity. And there is a trial going on, but it's in Europe or Japan, and there's been promising early results in Lupulin. So now we're going to spend, this is really, in my mind, having spent 35 years doing muscle disease, this is probably one of the major breakthroughs. And again, it's genetic. And this disease is called spinal muscular atrophy. It's when that lower motor neuron deteriorates and you lose it. And it's a recessive disease, and there are several variants. One with onset in infancy, the other is sort of before the age of 2, and then juvenile, meaning early, 10 to 20. Kids can typically walk. And it's due to deficiency of a gene called SMN1, and I'm going to do a little bit more about that. And treatment previously was supportive, and those infants typically died before the age of 2. And it was a horrible disease, and I can't tell you how many times I had to tell parents about this when I made the diagnosis. It was one of the hardest things I ever had to do. And you know what? It gets harder when you have your own kids, right? So it was really very difficult. But we have genetic modulation that has changed the course and face of this disease. And here you can see that SMA is caused by damage to a gene called SMN1. SMN1 is found in everybody, normally produces this full-length protein, and you can see those little round balls represent the protein, those gray balls. Oh boy, okay. But we all have a second gene called SMN2. SMN2, when it's translated to protein, doesn't quite make a good protein. And most of it gets degraded, and only about 10% results in SMN1 type protein. So it looks just like SMN1, except that when it's processed, I told you about those processing, it's processed to lack what's called exon 7, which is one of those pieces of DNA, and it gets rapidly degraded. 10% kind of skip over and somehow have it. In SMA, the severity of illness, because you make about 10% of normal protein, when you have a deletion of the SMN1 protein, which is what happens in disease, depending on the number of SMN2 genes you have, you may have enough reserve protein made that it can minimize the effects. So the severity of disease is really related to how many SMN2s you have. Now, what our new treatment does, and what the treatment that's available, it's called Spinraza, is that it basically makes SMN2 into SMN1 by forcing it to include that exon that's normally spit out. It's called splice modulating oligo, or an antisense oligonucleotide that alters the splicing, how that DNA is cut up, or RNA rather is cut up. And then it creates a situation where there's more SMN1 made from the SMN2 gene. However, on the horizon is Avexis. That's where we actually deliver the SMN1 gene with a viral vector. That has been nothing short of phenomenal as well. And we don't know how far along it is at the FDA, but it has been submitted to the FDA, and adults have to be tested as well. So very exciting, and again, genetic. And this just shows you kind of a look-see at what the differences were in the two studies. There were 2 studies done so far, one in infants and one in young adults up to the age of 15. And if you look at those red bars, those are the treated, and the sort of light gray bars are the placebo group, the sugar treatment. And you can see that kids made motor milestones when they were treated, and those that weren't treated deteriorated. It just, well, for somebody like me who's seen it for all these years, it's just been phenomenal. And then with the gene replacement, this shows you some of the early data with the viral replacement of the gene. And you can see the green is high dose, the blue is low dose, and the red is untreated. And again, in terms of motor development. So very exciting. And we're waiting to hear with bated breath what happens with the viral vector. Friedreich's, slowly progressive illness. It's a recessive, you can have heart disease, you get incoordination, some sensory findings. And again, there are some treatment strategies out there. Epi-743 was safe and well tolerated in phase 2. And what they did was they treated for 6 months. There was no significant improvement when you looked at sugar pill versus Epi-743, but everybody got the drug for 24 months after that. And it showed a significant improvement in function and progression when they compared it to what would have been predicted to happen, what we call a natural history cohort. So I'm sure we'll hear more about that. And then there's, I can't pronounce it, omavaloxone, which is an antioxidant that increases NRF2 that's in clinical trial. Now, the next thing we're going to talk about is neuromuscular junction disease, and specific myasthenia gravis. This is an immune system problem. So we're out of genetics now. Okay, take a deep breath. Won't be any genetics here. But this is an immune system problem where your own immune system attacks the junction between nerve and muscle. And, you know, usually it starts with droopy eyelids, and trouble speaking or swallowing can happen, or muscle weakness, and it's fatigable. You know, there may be some genetic predisposition to develop autoimmune diseases, and certainly in kids there are some genetic variants, but the classic myasthenia is an autoimmune disease. And basically we use medications that can improve the nerve-muscle junction communication. That's one way we treat it, but that's not treating the underlying disease. You want to alter the immune system, right? You want to change that immune system. So we use prednisone, IVIG, and some treatments that modulate the immune system to reduce it. Of course, the newest kid on the block, which was approved probably within, I guess, about a year ago now. I lose track of time. When you get this old, right, you lose track of time. But Solaris, which directly impedes what we call complement-mediated damage with immune system problems. So the immune system kind of recruits B cells, T cells, and they start to attack the junction, and they start to damage it in what's called a complement-mediated process. And complement is another protein in the body, and so Solaris blocks complement effects. And that's the newest kid on the block, and has been very helpful. It's not been widely used yet, but I'm sure it will be. But we have a lot of trials going on in myasthenia, and all of them are really directed at the immune system. Remember, there are two kinds of lymphocytes. There's T cell and B cell. 5 or 10? 5. Now they say, I told you 10-minute warning. I needed a 10-minute warning. So we'll see how we do. I'm trying, guys. If you use drugs that attack B cells or T cells, these are kinds of lymphocytes that can attack the junction. And so there's now trials going on. We've been using these drugs, or some of them at least, like rituximab, off-label for years. Now we're doing trials so insurers will actually pay for the treatments. I think that's one of the reasons we do them. So that's an important thing. And then I was going to tell you about Solaris. Now moving on to muscle. I'm going to just go ahead and talk about Duchenne. Duchenne is an X-linked. It's on the X chromosomes. That means mom carries it typically, and sons can have it. It causes progressive weakness with enlarged calves. And we have, a couple of treatments that are relatively new. Deflazacort has come to this country, and everybody knows. Now, deflazacort is a steroid like prednisone, but it does appear that it keeps kids walking longer than classically prednisone. There's some data that would suggest that, and it decreases the weight gain, but there may be some downside in that there may be an increased incidence of some other steroid side effects. And then there is the genetic treatment. Sorry, we're back to genes, and this is the drug Atrophy, in which the drug allows the body to skip over the damaged area of DNA, but only if you have a certain mutation which leaves exon 48. Remember, I told you there were all those exons that were put together to create the gene. So only if your problem is between exons 48 and 51 does Atrophy work. Now that's a hot spot in Duchenne where a lot of the damages are, but there are other areas too, and the companies are working on exon skipping over some of these other areas as well. And you can see in the lower panel, that was some of the data. The purple are treated and the yellow untreated in terms of loss of walking ability. And some of the trials that are coming, they're there is a viral vector that carries a surrogate gene called GALG-T2, and overexpression of that may help to alleviate some of the weakness. And then there's a couple of others. Follistatin is a muscle growth enhancer, and idabenone decreases respiratory decline in some early work, and that's under treatment. And then I promised to tell you about CRISPR. This is in mice. We take out the bad gene and put in the good one. And so you can CRISPR out even a portion of the gene. This has not come to human trial yet, but let's hope it does. I'm rushing because I have only about 2 minutes left now, probably. And I don't want people to not hear about their diseases. So myotonic dystrophy is, again, a disease of weakness, typically hands and feet. It can have systemic involvement, meaning heart, eyes, and other areas of the body, and stiffness, which we call myotonia, which is inability to relax. It is due to an extra piece of DNA called a trinucleotide repeat, and what happens is that this extra DNA gloms on to a protein called muscleblind. And muscleblind is a protein that modulates certain channels in the body called chloride channel. And so what happens is that it's glommed up and it can't go do its work. The strategy that's been used in the animal model, and hopefully will come to people, I know they're working on it, is again an antisense where you block that strand of DNA, that extra piece of material, with what's called antisense, so that it can't bind up muscleblind, and then muscleblind is free to go do its work. And so this is, again, genetic, exciting, and hopefully we'll see it come to clinics soon. FSH, facioscapulohumeral dystrophy. It tells you where the weakness is, the face, the shoulder girdle, and sometimes drop foot, limb girdle. Again, there are some trials going on. Phase 2 trial of that drug I told you about before, that ACE-023, that was the combo drug, and it enhances muscle size. HGH and testosterone in a single center, and creatine in Australia. So some work being done there. Limb girdle dystrophy. Okay, so I told you that this was at least, probably another 30 different diseases, and it causes, all people look the same with it. Progressive proximal weakness that wasn't Duchenne. That's how we diagnosed it, I think. And so, but now we know that you have to do the genetics and figure out which one. And it becomes even more important because we're doing gene therapy, and there's been gene therapy developed. And the interesting thing about this is, if you look at this picture down here, the circle, for people who can't see my red light, that circle shows you a muscle cell. And it shows you dystrophin, which is an anchoring protein between the muscle contractile apparatus. That's when I make a muscle, the sliding filaments contract, but we have to stabilize. If I didn't have stabilizing proteins on the cell surface up here and with dystrophin, my muscle would fall apart because that stress on the surface of the muscle would be too much. So dystrophin kind of anchors it to the cell surface, which includes what's called dystroglycans and sarcoglycans. And it turns out, you see, all of these proteins, if there's an abnormality, it results in what looks just like Duchenne, progressive proximal weakness. And these are the limb girdle dystrophies. And right now, the gene trials are in replacing the proteins in what we call the sarcoglycans. And there are 3 different gene trials going on where we're actually doing gene replacement. And hopefully that will turn out to be productive and may provide treatment. And finally, I'm going to finish off with, because I know my time is short and I didn't get to the inflammatory myopathies. I'm sorry if there's polymyositis and dermato out there, an inclusion body, but maybe next time. But we have a disease called Pompe's, which is a problem with the way muscle uses sugars. And in this case, we have actually developed a treatment. This, again, is a typically infantile disease. Infants are born with it, and they can die by 2 years of age. And we can now replace the protein using lumazyme and myozyme. There's a protein for adults and a protein for children, because adults can get it too, but it was the infantile variant that was so bad and difficult. So because of time, and I'm going to stop here and just end with, I went too far. You're actually now in, there we go. In conclusion, genetics really is an important gun in our arsenal. Understanding it is going to be key for you to understand some of the breakthroughs that we're making. It helps us not only to genetically replace, but also to understand mechanisms and cause that we can target, so we can target treatments. And we are using genetic modulation and manipulations to treat disease. So this isn't airy-fairy. It isn't next year. It isn't next decade. It's now. And we've only just begun. Thank you for your attention.
We have time for just a couple of quick questions. So if you do have a question, maybe those of you with a question about the inflammatory myopathies who didn't see your slide up there can ask. But we do ask you to wait for the microphone. We have somebody who's going to bring the microphone around, and we'll take a couple quick questions then. So just raise your hand and we'll get the microphone to you.
Hi, I just have a question about the inclusion body myositis. So I was diagnosed at 50, and so it's 10 years, and it's 10 years on prednisone. So as Dr. Bandy said, that at some point in time,
There you go.
We'll talk about bone issues. So is there anything new or different, like trying to come off of the prednisone but get too achy, having trouble with some fractures, skin tears, skin tanning, staining on my legs?
It's pretty difficult to get off steroid, and just trying to make sure that you do get you're taking your vitamin D and calcium, and you go to the rheumatologist for some of the newer treatments.
Can they use like Humira or anything with the inclusion body? Because I just started seeing a rheumatologist, and he's going to try and take me off the prednisone 1 milligram at a time, and that with increasing methotrexate and all the side effects from that, and the folic acid.
Well, typically we try not to even use immunomodulation now. For some people try IVIG for a while. So IBM is really interesting because a subpopulation, about 50%, will have an antibody, a specific antibody, a cytosolic, I forget, I know it's 5' HCC. But if you have that antibody, I will try IVIG personally. I'll do it because it says to me it's probably immune mediated. And in fact, some of the therapies that are being looked at, like abatacept, which I put up for you, are actually immune modulators, but the others are more aimed at muscle growth and muscle strength. It is really difficult because in the old days, a lot of people with inclusion body myositis, there were 2 different diagnoses they got. ALS was one of them, and they would show up with concern for ALS because they can look very atrophic and look like ALS, and polymyositis, and then if they're diagnosed as polymyositis, people were placed on steroid, and then they get hooked on it in the sense that when you try to taper it, you do get the achy breakies because we all have osteoarthritis, and so I always just tell my patients, use some of the non-steroidals, Motrin, aspirin, as I try to taper you, and it's best to be off. But there is a huge interest in bone health, and I think you heard that there is. And the rheumatologists are the ones who, at this point, take a hand in treating the bone health issues with steroids.
All right, thank you.
I don't know if that was helpful.
Thank you.